All right. Thank you so much, Megan, for that introduction. And thank you for inviting me to come and talk to you all. I'm really excited to talk to you all about childhood speech disorders tonight. So I'm going to go through a variety of things. And then at the end, hopefully, we'll have plenty of time for questions and discussion. So the goals of my talk tonight are to help you understand different types of speech sound disorders in children, understand about how speech sound disorders are diagnosed, to kind of go through typical speech development and some current research on development of speech sounds and speech intelligibility, and then kind of talk about some red flags for speech sound disorders. I'm going to talk a little bit about current research on treatment approaches for different types of speech sound disorders, and then provide some tips and resources for parents. So I'd like to start by showing this figure, which is from the American Speech Language and Hearing Association's website. And it kind of shows that speech sound disorders is an umbrella term that encompasses a variety of disorders that all affect intelligible and accurate speech production in children. So some have organic causes, that are structural, sensory, or neurological in nature. So these include children who have trouble learning to produce speech sounds due to hearing impairment, children with craniofacial anomalies like cleft palate, or other kind of structural deficits, and children with neurologically based motor speech disorders. But the majority of speech sound disorders in children are functional, meaning there's no known cause. So these are largely diagnosed as phonological or articulation disorders, and they can occur in isolation or in conjunction with language impairment or other kinds of neurodevelopmental disabilities. However, it's important to keep in mind that many children with neurodevelopmental disabilities have multiple issues that simultaneously affect their speech development. So a child could have hearing loss and craniofacial difference and neuromotor impairment and language learning difficulties that all affect their speech sound production. So there are a lot of kids who don't cleanly fit into just one of these categories. I'm going to focus mostly today on talking about functional speech sound disorders and motor speech disorders in children, because this is the space where differential diagnosis is most challenging. And also, there are the types of speech sound disorders that are really commonly seen in children with neurodevelopmental disabilities. So to start, I'm going to talk for a minute about the theoretical level of breakdown associated with these different speech sound disorders. So this model here on the right is a simplified version of Lavelt's model of speech production. And so it shows that speech production begins with idea formulation. And then language processing is needed to translate this idea into words and phone and grammar to make a grammatically correct sentence. And then that's translated into a sequence of speech sounds or phonemes. So following these language processes, the top three blocks, then you get into the motor component of speech production. So that involves motor planning and programming that translates what you want to say into a sequence of motor goals. And then motor execution, which is where the brain is sending signals to the actual muscles to move in a certain way to produce speech. So phonological or articulation disorders are theorized to result from breakdowns at this phonological encoding level, or the encoding that where the sounds needed to produce the utterance. Although there are some competing explanations about that level of breakdown. Childhood apraxia of speech and dysarthria are motor speech disorders, and they're hypothesized to be due to breakdowns at the motor planning and execution levels, respectively. There's been a lot of controversy over the years, particularly about diagnosis of childhood apraxia of speech. But the reason that identifying this level of breakdown is important is because the type of intervention needed for motor speech disorders is different from the type of intervention needed for phonologically based disorders. Phonological and articulation disorders are common in young children and decrease with age, as many resolve with therapy. So about 3.5% of young school-age children have speech sound disorders. And the etiology is typically idiopathic. Co-occurring language impairment is common, occurring in about 11 to 40% of these children. Also, one of the reasons that early treatment is important for kids with speech sound disorders is that we know from research that speech sound disorders increase risk. Oh, I don't know why I advanced there for later reading disorders, and that early intervention can kind of help with decreasing that risk. So the speech characteristics that define phonological or articulation disorders are first, that errors tend to be consistent. So children might have multiple sound errors, but they follow predictable patterns. So some of these patterns can be described as phonological processes. An example of this would be a child who consistently produces K and G sounds as T's or D's. So said like cat for cat or dote for goat. And the kinds of sound errors that children with speech sound disorders can have or can be substitutions where they switch sounds, distortions where they produce a sound a little bit inaccurately, or omissions where they leave out sounds altogether. Research has shown that many children with these speech sound disorders can have speech perception deficits too. So they may have a trouble hearing the difference between sounds or reduced ability to discriminate between the sounds they're hearing. Children with phonological and articulation disorders typically have a normal speaking rate and normal prosodic variation, meaning they use normal intonation patterns in their speech. And because it's not a motor-based impairment, the strength and range of their movements in their speech muscles is typical. So I'm going to try playing this sample of a child with a phonological disorder. I'm not sure how the audio is working, so I'll play it and hopefully you'll be able to hear it.
Jump over. So you jump and over. You jump to the rope, then touch you.
Okay. Childhood apraxia of speech is a much less common type of speech sound disorder. So often, childhood apraxia of speech has an idiopathic etiology as well, meaning there's no known cause. And that can add to the difficulty with differentiating between childhood apraxia of speech and phonological disorders. But it's also the case that CAS is much more prevalent in some types of neurodevelopmental disabilities. So although there are no clear neural markers of childhood apraxia of speech, it's assumed to be due to a neurologically based deficit in motor planning or programming for speech. Children with CAS often have co-occurring language impairment, and they are also at increased risk for reading disorders. In addition, recent studies of kids with CAS have shown that many of these kids have global motor deficits, and developmental coordination disorder is common, suggesting there's core deficits underlying CAS that are not limited to just speech. CAS, like other speech sound disorders, is diagnosed based on the presence of particular speech characteristics. So some of the core things that SLPs listen to when they're trying to diagnose apraxia is the characteristics of the child's prosody and articulation. So in terms of prosody, kids with CAS tend to have a slow speaking rate. They make lexical stress errors, meaning they put the stress on the wrong syllable of the word. So instead of saying banana, they might say banana, and they might separate the syllables like banana, and that would be syllable segregation. So they have problems with smoothly transitioning between syllables. That can result in sort of a choppy quality to their speech. Articulation errors for kids with CAS tend to be inconsistent. So it means that they produce the same word multiple times in a row. It may come out differently each time. So this is different than the phonological or articulation disorders where errors are generally consistent. Kids with CAS may often make errors with vowels and distortions of speech sounds, which is also not so common in children with phonological disorders. Lastly, they also tend to have more difficulty in more complex words. So for kids with CAS, they might be able to say a single syllable word very clearly, but when they get to a multi-syllable word, then they have a lot more difficulty producing those kinds of words. Okay. So dysarthria is another kind of motor speech disorder. And this is a neuromotor speech disorder that affects execution of speech movement. So it results from impairment in strength, speed, range, tone, coordination, or accuracy of speech movements. The specific speech features that children with dysarthria have depends on the underlying neuropathology. However, there's not necessarily a direct mapping between speech symptoms and what part of the brain is damaged in the same way that there is for adults. Dysarthria can vary in severity very widely, from very mild impairment where the child is very intelligible but has some noticeable differences in the naturalness or quality of their speech. And it also can be very severe. So when motor speech impairment is so severe that the child has no intelligible speech, we refer to that as anarthria. A key difference between dysarthria and other types of speech sound disorders is that in dysarthria, all speech subsystems can be involved. So respiration, so the breath support for speech, phonation or voicing, voice quality, resonance, so how nasal a person's speech is, and articulation. So other types of speech sound disorders tend to be limited to the articulatory system and can include prosody deficits, as I mentioned before. The kinds of speech features that might be associated with deficits in the respiratory or phonatory system include things like reduced breath support, atypical or excessive pausing, differences in voice quality, reduced intonation, and difficulty regulating pitch and loudness. Hypernasality can occur intermittently for children who have trouble with control of their velum, or their soft palate usually closes off the nasal cavity for certain sounds. And if children have weakness in that part of the body, then they can have hypernasality, or their speech can sound too nasal. And then common articulatory characteristics of children with dysarthria include imprecise articulation. So it may be like a slushy quality to their speech, a slow speaking rate, and they also have distortions of vowels and consonants very commonly. Okay, so here is an example, hopefully you can hear, of a child with mild dysarthria secondary to cerebral palsy. So note that although his intelligibility is good, he has to take a breath in the middle of a short sentence, and his voice quality becomes gravelly at the end of the sentence, which is likely happening as a result of him running out of air. Even children with mild dysarthria can benefit from speech intervention to help them maximize their speech function. That's playing, yes. So I couldn't hear it. Could you hear that? Okay, I'm going to play it one more time while I'm not talking.
The garbage truck came to pick up trash at my house yesterday.
Okay. So hopefully you could hear that and hear some of the different characteristics in his speech there. Okay. Dysarthria is typically associated with neuromotor disorders. So in children, cerebral palsy is a common cause. Dysarthria is also common after severe traumatic brain injury in children, and associated with many other genetic syndromes and other kinds of neurodevelopmental disabilities. And co-occurring language or cognitive impairment is also common in kids with dysarthria. So for kids with dysarthria particularly, but also kids with childhood apraxia of speech, they often have a lot going on. It's not only their speech. And so for families who have kids with CAS and dysarthria, they may be trying to balance multiple things and figure out how to prioritize different areas for treatment for their child. And that can make it more complicated. So we're going to talk a little bit more about that when we get to kind of treatment. But regardless of the type of speech sound disorder, all of them can have important functional impacts on children's communication function. Most speech sound disorders result in reduced intelligibility, which can impact a child's ability to functionally communicate with others, including peers, family members, and teachers. And research has shown that speech sound disorders can have long-term negative impacts on social participation and independence and quality of life. So early and accurate diagnosis and intervention is really important for these kids to make sure that we're getting them the targeted intervention they need as early as possible. All right. So I'm going to just talk a little bit about kind of challenges to diagnosis for a couple minutes. So these diagnostic categories I've been talking about are all diagnosed by SLPs based on the presence of particular speech characteristics. So ideally, to differentiate these disorders, we would have unique, non-overlapping characteristics that could clearly help us determine whether the deficit is phonological, motor planning, or motor execution, as is shown in the left. However, the reality is that speech features overlap between these categories, making differential diagnosis challenging in a lot of cases. In addition, many kids with neurodevelopmental disabilities have multiple challenges, as I mentioned before, and can have other kinds of challenges in motor planning and phonological skills that further complicate this differential diagnosis. And additionally, kids change over time. So typically developing kids are not expected to master all of their speech sounds until age 7. So particularly at young ages, it can be really challenging to differentiate between something that's a delay and a disorder in speech production. We, speech language pathologists, have a good normative information about speech sound acquisition, but we have much less information about development of these kind of motor speech features that we use to help with this differential diagnosis of motor speech disorders. So for all these reasons, classification of speech sound disorders remains an ongoing topic of research and source of debate in the research community. Speech language pathologists' job when evaluating children with SSDs is to conduct a comprehensive assessment that typically involves a combination of standardized tests and informal measures like having a child repeat different words and sentences, collecting a speech sample in spontaneous conversation, and then doing a careful analysis of the child's speech error patterns and speech features to decide on a diagnosis and make a treatment plan. I want to stress that because of the complexity in making these diagnoses, SLPs are really the professionals who should be making these diagnostic determinations. But we don't always have all the tools that we need. And one of the research projects that I've been working on with 2 of my colleagues, Jenny Uzini-Siegel and Ruth Stuckel, is a clinical tool to help with this differential diagnosis between apraxia and dysarthria in particular. So we call this tool the ProCAD, or the Profile for Childhood Apraxia of Speech and Dysarthria. And it's designed to help SLPs identify speech features associated with dysarthria in children and CIS in children. So this tool explicitly considers symptoms that are unique to the dysarthria, symptoms that are unique to CIS, and features that overlap between the two. The ProCAD also helps SLPs assess a child's speech features across all speech subsystems, which can help with treatment planning. So this is particularly important to consider for treatment planning in children with dysarthria, which we will discuss more later. So I'm happy to provide more information later about this tool if people want to ask questions about it. It's freely available in an open access tutorial that we published in LSHSS in 2022. Okay, so even though SLPs are the ones who make these diagnoses, it's important for parents and all professionals working with children to know important developmental milestones in speech development in order to make appropriate referrals to SLPs. So this is a chart that reviews some major speech milestones. So babbling typically starts around 7 to 9 months of age, and children are able to produce a variety of different vowel sounds and some consonant sounds. First words typically appear around 12 months, and by 18 months, children should be using about 50 different words and starting to combine words. But at that point, their speech may not yet be clear. Between 2 and 3 years of age, children should be able to correctly produce most vowel sounds and some consonant sounds, and they're starting to produce more short sentences. But they may still have a bunch of speech errors at that age, and they may not always be understood by unfamiliar people. Between age 3 and 4, children's speech and language skills expand and they're able to speak in longer sentences. By this age, they should be able to produce all of the syllables in a word, and they may have some sounds that are incorrect, but their speech should be usually understood by unfamiliar people. And then between age of 4 and 5, children should be producing grammatically correct sentences. Most consonants should be produced correctly, and their speech should be easily understood in conversations. So there's a lot more detail about communication milestones that you can find at this link from ASHA at the bottom here. But these are some of the major ones just related most specifically to speech development. This slide shows an infographic from a large-scale study of normative speech development in English-speaking children and provides a helpful reference showing the average age at which children acquire different speech sounds. So for children who speak English, who are learning English as their first language or their primary language, at age 2 to 3, you can see the sounds here at the bottom that are the earliest developing. So the p, b, d, n, t, k, g. So these are the earliest developing sounds. And then it shows the average age at which kids master these sounds, with j, and being the latest developing sounds. Most phonological error patterns disappear by age 4, and kids start to be able to produce consonant clusters, but some of their more complicated consonant clusters, especially ones with R's in them, may still not be quite accurate into the early elementary years. It's important to note that these norms are for English-speaking children, and that children growing up speaking different languages can have some differences in the order of acquisition of speech sounds, and there is normative information on other speech sounds as well, in other languages as well. Another important piece of information that all providers and parents can keep in mind when seeing children is their intelligibility level. So the figures on this slide are from a recent publication by Dr. Katie Husted at the University of Wisconsin and her colleagues. And they did a large study of over 500 typically developing children and developed growth curves on trajectories of intelligibility development between ages 2.5 and 9 years of age. So you can see the curves in the figures here kind of look like developmental growth curves you see when you take your child to the pediatrician's office and they map their height and weight over time. And the idea is that these growth curves could be used in a similar way to look at, what is your child's trajectory, and are they staying on their trajectory over time, and where are they falling with regard to the average range for their age. Results of this research yielded some kind of benchmarks here. So for single words, an average child should be 50% intelligible by 31 months of age, 75% intelligible by 49 months, and 90% intelligible by 83 months. In multi-word utterances, the numbers were a little bit different. So kids should be 50% intelligible by 34 months, so just before age 3. 75% intelligible by 46 months, and 90% intelligible by 62 months. Now, one thing that's important to keep in mind is how intelligibility is measured in this study. So intelligibility levels can vary a lot depending on how they're measured. So when we're talking about intelligibility, we're talking about the percent of words that a child produces that you can understand, that's understood by a listener. If the listener is a parent, the parent is not going to understand a lot higher percent of words than an unfamiliar listener would, because you're familiar with the child, you know what they're saying. And any close relatives or speech therapists who work closely with your child are going to understand more of your child's speech than someone who's just a naive listener that doesn't know your child. So the way that these intelligibility data were all measured was by recording children's speech, having unfamiliar listeners come in and listen to recordings of the child producing the sentences and typing out what they think the child said. Okay, so that is really kind of a conservative estimate of intelligibility, because it doesn't provide, it's what an unfamiliar listener would understand without any contextual cues available. So I think that's an important context to keep in mind when looking at these numbers. So Really, if you're thinking about how much you understand of your child's speech, it should be quite a bit higher than this at these ages. All right, so to summarize a little bit about typical development and what we know about the typical speech development, here are some red flags for signs to look for that should make you think maybe I should have my child evaluated by an SLP. So if a child is late to start producing words at all, has no or very few words by 18 months of age, or produces a very limited variety of consonant or vowel sounds around 18 months of age, those would be red flags to get your child evaluated. There's been research showing that children with CAS and dysarthria are usually very quiet babies, have less babbling, and have a less variety of consonant and vowel sounds that they produce in their babbling. So while it's really hard to make a definitive diagnosis of childhood apraxia of speech or dysarthria at those very young ages, those are some of red flags for that. If a child around age 3 or after is leaving off beginning sounds of words or emitting a lot of sounds, is still really hard to understand between ages 3 and 4, or is getting frustrated a lot when they're not understood by others, those are some other red flags that it might be time to get your child evaluated. All right, so now I'm going to switch gears and talk about intervention. Okay, so in terms of treatment for speech sound disorders, the good news is that there are many evidence-based interventions for speech sound disorders, and many children respond very well to therapy, particularly at young ages. There are also a lot of new approaches that are coming out and have gaining research support, as well as other intervention approaches that have been around for a long time and also have a strong evidence base. Some of these approaches focus on treating underlying phonological disorders, and methods of treatment are designed, and then there's other methods of treatment that are designed specifically for motor-based speech disorders like CAS and dysarthria. Biofeedback approaches are also gaining research support, and these include things like using ultrasound or a lot of electromagnetic articulography to help patients visualize how to change their articulatory movement. So they're using like an ultrasound probe under the chin, and you can see the shape of your tongue when you're producing different sounds. And that visual feedback can be really helpful for some kids and some people to help improve the accuracy of their speech sounds. These kind of biofeedback approaches have been studied most in older children with persistent difficulties with specific sounds, like children who have trouble with R's and S's that have been resistant to treatment. So that's the population that's been studied most in. So in terms of phonological approaches, there are many phonological approaches that are supported by research evidence. Some of them are designed for children with only a few errors, some of those phonological processes that I mentioned earlier. And then there are some approaches that are more appropriate for children with a lot of speech sound errors and a limited number of speech sounds in their inventory overall. But a key principle of all of these approaches is that they're designed to help children learn how sounds are organized in words and to improve their phonological systems. So an example of this, if you had a child who is producing, is substituting their K sounds with T sounds. So instead of key, they say T, for example. Then these phonological approaches would focus on contrasting the word key and the word T to help teach the child that these are two different sounds, the k and the t, and they change the meaning of the word. And so that's kind of the basis of these approaches, is to help children understand these two sounds are different and they signal a difference in meaning. And by working on those different kind of contrasts can help children improve their phonological knowledge and accuracy in their speech sound production. But one important thing about these phonological approaches is that they assume the child's motor system is intact. So for children who have childhood apraxia of speech or dysarthria, and that's the primary issue going on, phonological approaches are not the best way to go, and children may show limited improvement with a phonological approach if it's really a motor-based problem. So in contrast, motor-based treatment approaches focus on helping the child improve accuracy of their speech movements. So this might look more like working on syllables or words than individual speech sounds, because children with motor speech disorders can have trouble transitioning between consonants and vowels or between syllables. And if you think about the vowel that comes after a consonant, the way that your mouth moves can vary a lot depending on which vowel comes next. So if you say the word boo, you start with your lips together and then they're already kind of rounded for the ooh sound. But if you're saying B, your lips are already spread to start and your lips are going out for the B. So the actual movement involved in boo versus B is really different, even though both have that B sound. So these motor-based approaches really focus on that movement gesture rather than the individual segment. These motor-based approaches also use principles of motor learning, which are basically components of how we structure practice within a therapy session and how we provide feedback that we know can be helpful for learning new motor skills. And this comes from limb movement literature about what we know about how people learn to shoot baskets and do all sorts of other kind of motor skills. And they've been increasingly studied in their application to speech. For children with dysarthria, motor-based treatments also need to consider all speech subsystems and might focus on improving breath support and voice quality in addition to just articulation of speech sounds. This chart shows a few motor-based approaches designed for children with childhood apraxia of speech and dysarthria. And there are links to descriptions to websites that have more in-depth descriptions of them. So briefly, dynamic temporal tactile cueing, or DTTC, and REST, or rapid syllable transition training, are two treatment approaches that have been developed specifically for kids with childhood apraxia of speech, and both have pretty good research support at this point. DTTC is particularly appropriate for younger children who have really limited speech, and it focuses on using tactile cues, so the clinicians touching the child's face and modeling and doing simultaneous production and giving a lot of cues and then gradually fading them to help children improve production of their speech sounds. And the REST approach focuses on smoothness of transitioning between syllables and accuracy. So it incorporates prosody, transitioning between syllables, and speech sound accuracy all together in that approach. Two dysarthria treatment approaches that have some of the strongest research evidence at this point are speech intelligibility treatment. This is developed by Dr. Erica Levy, who's at Columbia University, and it focuses on prompting children with dysarthria to use a strong voice and a big mouth when they talk. And then another treatment approach that was originally designed for adults, but has been translated to kids is LSVT, or Lee Silverman voice treatment. And this is a treatment that was originally designed for adults with Parkinson's disease and focuses on speaking loud and increasing loudness. But it's since been studied in children with dysarthria, particularly in kids with dysarthria secondary to cerebral palsy. And it's been shown to have some good benefits on improving intelligibility, at least for some kids. Compared to CAS, there's relatively little research on speech treatments for children with dysarthria, but we do know that speech modification strategies that engage breath support and voicing can help improve speech clarity for some kids. So that involves things like speaking loud, like these treatments that I just talked about too, or using a slow rate, or emphasizing keywords. So those are examples of different speech modification strategies. But the research that's been done on this has shown that children with dysarthria vary widely in how they respond to these cues, And at the moment, we don't really know how to figure out which strategy will work best for a particular child. So this is something that I'm working on right now in a current research study I have going on in my lab. So we are recruiting children and older children and adolescents with cerebral palsy and dysarthria. And we're focusing on comparing the efficacy of 3 different speech modification strategies and comparing how we can tell, or examining how we can tell which strategies are likely to work best for specific kids. So in this study, we asked kids to say a set of sentences using 3 different strategies, and we audio record them. And then we also record movements of their lips and jaw using an optical motion capture system. So you can see in the picture here, this little girl has some reflective stickers on her face. There's one on her forehead that has 4 stickers, and then she has stickers around her lips and jaw. So those are just reflective markers. And we have an optical motion capture system that tracks movement of those reflective markers in 3 dimensions while the children are talking. And that allows us to examine how children are changing the range of their lip and tongue jaw movement and the speed of their lip and jaw movement while they're talking and in these different speech conditions. And that can help us understand more about how these strategies work and what kind of changes kids are making that is actually underlying improvements in speech intelligibility. So we're currently looking for more kids who want to participate in this study. So if you know any children who you think would want to participate, please reach out. Okay, so overall, it's important to know if a child's speech sound disorder is more phonological in nature or motor based, because as I've been talking about, different treatment approaches are needed in each case. But there's also some other important considerations. One thing is that early intervention is important. So it's important not to take a wait and see approach because kids with SSDs are at increased risk for problems with reading and spelling later on. Early intervention can help reduce that risk. It's also true that other referrals and professionals might be able to help you understand your child's learning as a whole and be an important part of your child's team. So a reading specialist could be involved, neuropsychologists, and for children who have more general motor impairments, occupational therapists and physical therapists are often a key part of the team. So the team will vary depending on whether it's a school setting or a medical setting. But a lot of times working together and having good communication between the different specialists working with your child can be really helpful in coming up with the best approach to help the child overall. Another thing I want to mention here is that even though I've been talking about speech strategies to improve speech production and speech intelligibility, it's also the case that augmentative and alternative communication can be a really important tool for children with speech disorders, particularly children with motor speech disorders and kids who have really impaired intelligibility. So augmentative and alternative communication can include lots of things, including gestures and signs to picture boards to high-tech devices that generate sentences. It's important to know that AAC can help reduce frustration for kids who have trouble being understood. It can help support development of language skills and foster successful communication and socialization with peers. And it's not an either or thing. You don't have to choose working on an augmentative communication device or speech. It can be done together. And AAC can provide a way to minimize frustration and promote successful communication for a child while they're working on improving their speech production skills. So even if they won't need an AAC device long-term for communication, it can still be a really important tool in the short term to help the child's functional communication. Also, research has shown that AAC does not inhibit development of spoken language. So sometimes parents have that concern, but we know now that that is not the case. All right. So here's some tips, some kind of tips for parents. I know there's maybe some parents here and some SLPs here. So as a parent, it can be overwhelming to try to take in lots of information from clinicians sometimes, especially if the diagnosis is new, and especially if you have a child who has multiple needs. So here's just a few tips to kind of keep in mind for parents related to your child's speech and language therapy. So one thing is to ask your child's SLP for information about the approach they're using in therapy with your child and ways you can help your child practice at home. Many SLPs are probably already talking to parents about that and providing home practice opportunities. But if you're not sure if the child's therapist is using a phonological approach or a motor-based approach with your child, it's worth having a conversation with them about what approach they're choosing and why, and how that's helping address your child's needs in the best way. It's also important to ask your child how they feel about their speech. And there's this, I wanted to kind of bring your attention to this tool called Speech Participation and Activity Assessment of Children, or the SPA-C. This is a freely available, you can download it at this link. And it's a way for parents or speech pathologists to talk with kids about how they feel about their speech in different situations. This can be really important information for making sure that the goals that your child's working on in therapy are meaningful for them and are addressing the challenges that they're experiencing in their life with their communication. It's also important as parents to talk with your child's SLP about what's going well for your child in terms of communication and times it's most challenging, and to make sure that your and your child's priorities are represented in their goals. And I think the more collaboration there is between the speech language pathologist and the parents, it can only be helpful for making sure that the therapy is as effective as it can be for your child. And one other thing that I didn't put on this tips page, but I'll mention quickly because we have a few extra minutes, is that for some children, I do a lot of work with children with cerebral palsy who have lots of therapists. So they see PTs and they see OTs and they see speech and they see sometimes somebody's different for feeding. Sometimes they have vision and they have multiple needs, and it's hard for parents to give every area priority all of the time. And so it's okay to figure out, this is what we need to focus on right now for my kid, and to then switch those priorities later on depending on your child's needs. So it might be that making sure that the child's feeding is established and safe is the first priority, and then at some point in time maybe PT is taking priority, and then another point in time communication is taking priority. And so I think that those are things that are changing, and you can communicate with your child's team too, and can be helpful to kind of keep in mind that it's okay to prioritize some things over others at different points in time. All right. Here are some other resources that where you can find some more really helpful information. So the Apraxia Kids page has a lot of great information about childhood apraxia of speech. Has information about current research and clinical trials going on, as well as lots of resources for parents about what apraxia is and different treatment approaches. For kids with cerebral palsy, the Cerebral Palsy Foundation's resource page, cpresource.org, has lots and lots of great information for families. The American Speech, Language, and Hearing Association's website also has a lot of great information for parents about communication milestones, and has information about different assessment and treatment approaches for speech disorders. And then last, this website has a lot of information about multilingualism in children's speech. So I talked about the typical order of acquisition of speech sounds for children who are speaking English. but you can find at this website information about what the order of acquisition is expected for children speaking different languages, and find charts that are like the treehouse chart I showed you, but for different languages at this website. There's also different assessment tools that are freely available here and have been translated into multiple languages. So for SLPs, you can print out different forms to help us with assessment of intelligibility and participation in multiple languages and give those to parents. All right. Well, I got through that a little faster than I thought. But thank you all very much. This is a picture of my daughter when she was 3 months old in my lab, and this is the optical motion capture system that we use and some references. So I will pause this, and I'm happy to answer any questions that you all have.
Thank you so much, Dr. Allison. That was fantastic. I have a question. I feel like this comes, so I'm as a speech therapist, I feel like this comes up a lot in terms of how home practice may differ in terms of sort of both the frequency and the types of recommendations you're making. I'm wondering in your research if you've come across good answers for families in terms of whether the diagnosis is CAS or dysarthria, or if it's phonological, how that might change how frequently you're expecting to practice at home to see progress.
That's a good question. I don't know that there's any sort of hard and fast recommendations about that at this point, but I think that one of the things that we do know about principles of motor learning, and so for children with apraxia, for example, is that they do better with distributed practice, so more frequent, shorter blocks of practice throughout a week than one longer block of practice. So 3 20-minute sessions spread out throughout a week is better than one 60-minute session for most kids. And so while that may not be possible in a lot of clinical settings, like that's all well and great. Hold on, the light just showed a shine, turned off in the room on me. I realize that in a lot of clinical settings, that's not really a possibility, or you don't always have the flexibility to do that. So I think in those situations, that's what you can talk to the parents about. If you could do this, 5 minutes a day, 10 minutes a day, every day with your child who has apraxia, with these targets, with just a couple of targets that they're having some success with you within therapy, and having the parents have them get some practice in every day or every other day, having that frequency throughout the week can be really helpful. And I think it's more important for children that have a CAS than children with phonological disorders. They also will benefit from the home practice, but I don't think that the distribution of the practice is as important for the kids with phonological disorders.
Great, thank you so much. It looks like there's a question in the chat. I can read it out loud for you. So Kelsey says, I know a child I find hard to understand. Their words can be merged and mumbled can be merged and mumbled. The parents can understand. And I notice the teachers aren't saying anything. She's about 6, and I do know she is struggling with reading currently. Yeah, so I guess maybe what would be your recommendations for a child like that?
So let me take a look. So the child's speech can be merged and mumbled. I think that can be a variety of things. It can be that in more challenging tasks, I've seen kids who tend to kind of just have smaller speech, and tend to mumble their words more, don't produce their words as clearly in tasks that are linguistically challenging. But it also may be the case, it sounds like this is a child where it makes sense to do, a good speech evaluation to figure out, are their speech patterns consistent across speaking tasks? What are the conditions under which their speech is more clear or less clear? Okay, hang on, I see. Snackers will think, and I'll be asking, what did you say? Because I could hear bits and pieces. Okay. So I think that if a child's speech is unclear like that in conversation on a regular basis, then I think it warrants a full evaluation to see what's going on. I think just based on that, it's hard to know, is that a motor speech impairment? Is it not a motor speech impairment? But I think you can kind of, if you look at the child's speech across, like a single word artic test and repeating a set of sentences and spontaneous speech, and repetition of more complex words, and look at what are their speech characteristics across these different settings, then it can help you figure out what is really going on. Is it mostly articulation that's the problem? Is the child running out of air and has low volume, and it's because of a breath support issue? That's a possibility that if the child's talking quietly and sort of sounds aren't coming out clearly. So I think those are the things I would think about wanting to look at carefully, is looking at, how are all of their speech subsystems doing, and what aspects of their speech are contributing to this reduced intelligibility, and then go from there.
Great. If anyone else has questions, feel free to unmute yourself or pop it into the chat. Thank you so much, Dr. Allison. I feel like I learned so much. So Dr. Allison was my professor at Northeastern several years ago, and I feel like I'm continuing to learn things from your research. You're doing really cool stuff.
Well, you're very welcome. I was more than happy. This was really fun to talk to everybody. And please, everybody can feel free to reach out to me and email me directly with any questions. Megan can share my email address. So please do reach out if you have any questions, and I'm happy to share the slides and resources on these slides with links for anybody who would like to have them.
Great, thank you so much. We'll end the presentation here. If anyone wants to watch the recording, I'll be sending out an email with a link to our YouTube page, which will also they'll have this presentation and then some of our past presentations as well. Great,
All
thank you
right.
so much for joining us. Have a good one.
Thank you. Have a good night.
Thanks, bye.
Bye. Bye, Ami.
Hello.
Hi. Thanks
Hi.
for coming.
Yes,